بسم الله الرحمن
Uh,
الرحيم. السلام عليكم ورحمة الله وبركاته. Good morning everybody for our uh, monthly lecture academic activities belong to the Pan-Arab Congenital Heart Disease Association. Today my pleasure to present my colleague, my friend Dr. Ali Al-Akhfash to present neonate with cardiogenic shock. Dr. Ali is consultant pediatric cardiologist and interventionist. He is the head section of pediatric cardiology at Prince Sultan Cardiac Center, Qasim. All the best, Dr. Ali, and I am sure it will be a great lecture.
Bismillah, Assalamu alaikum. Good morning, everybody. My lecture, actually, I modified the title a little bit, and I put it as the Neonatal Cardiac Emergencies and Prostaglandin Deficiency. I try to be presenting some basic knowledge merged with advanced pediatric cardiology knowledge. We know that congenital heart disease is the most common birth defect, affecting almost 80,000 live births each year. It's the most common congenital birth defect. And in Qasim, we did our research and we found that the incidence of severe congenital heart disease is about 5.4 per thousand live births. What do we mean by severe congenital heart disease? It means that the infant will require intervention in the first year of life. And also pediatric patients as well as neonates are prone to develop acquired heart conditions. We classify congenital heart diseases into critical, severe, moderate, or mild. Mild, moderate, severe, or critical. Mild, in which the patient will not require any intervention, and the most common example of such thing is a small ECD, small mid-muscular VCD, bicuspid aortic valve with no ES, no EI. Moderate congenital heart disease, the patient might be symptomatic and he might require interventions like moderate VCD, moderate pulmonary stenosis. Severe congenital heart disease, in which the patient will require intervention in the first year of life, like large VCDs, ECD, AV canal defect, anticoagulant follow. And critical congenital heart disease, in which the patient is having a life-threatening condition, and we cannot discharge this neonate from the hospital unless we do intervention for him either by cath or by surgery, like patients with TGA and prostaglandin-dependent lesions. The objectives of my presentation will be to recognize cardiac emergencies specific to neonates, understand physiology of different types of cardiac emergent conditions, recognize prostaglandin-dependent congenital heart diseases in the neonates, understand the physiology and dosing of prostaglandin infusion, identify neonatal cardiac arrhythmias and their acute management, discuss some points about neonatal cardiomyopathies and their emergency management, no immediate treatment of different cardiac emergent conditions, review case-based scenarios for critical decision making, and neonatal cardiac emergencies are emergencies due to congenital heart diseases, which most of the time are ductal dependent lesions, or related to neonatal arrhythmias, or related to neonatal myocardial dysfunction. Patients with significant congenital heart diseases might present with signs and symptoms of congestive heart failure, cyanosis, or shock. Infants might manifest as congestive heart failure as feeding difficulties, tachypnea, wooziness, or agitation. And the physical examination might reveal a murmur, tachypnea, diaphoresis, feeding intolerance, or hepatomegaly. And if you have a neonate with active pericardium, this is a cardiac condition until proved otherwise. No neonate will have a pulsatile pericardium. A normal neonate will have a pulsatile. If you have a pulsatile pericardium, visible pericardial pulses, this is abnormal. So Neonatal congenital heart diseases or cardiac emergencies are like patients with ductal dependent congenital heart diseases like critical left-sided obstructive lesions, critical right-sided obstructive lesions, and parallel circulations like patients with TGE or ventricular inversion, and the cyanotic congenital heart diseases. How to evaluate the neonate with cyanosis? The cyanosis is present when there is inadequate pulmonary blood flow, mixing is inadequate in the setting of parallel circulations, like patients with TGE. There is obstruction in the pulmonary venous return. There is significant right to left shunt, or the patient is having inadequate ventilation. Congenital heart diseases that might present with cyanosis include DTGE with intact ventricular septum, severe tetralogy of Fallot, critical pulmonary stenosis, pulmonary atresia intact septum, severe Epstein anomaly, tricuspid atresia, obstructed TEBVD, single ventricle pathologies with inadequate pulmonary blood flow, isolated ventricular inversion. So just to remember cyanotic congenital heart disease, remember these mnemonics, like 1 is truncus arteriosus, 2 is transposition of great arteries, 3 is tricuspid atresia, 4 is tetralogy of Fallot, 5 is total anomalous pulmonary venous return. So prostaglandin dependent lesions. To understand prostaglandin dependent lesions, we have to go back to the fetal circulation. We know that we have the placenta, we have a high pulmonary vascular resistance, and we have low systemic vascular resistance. So low systemic vascular resistance is related to the presence of the placenta, and high pulmonary vascular resistance is related to the lungs are depleted and filled with fluid. And we do have 3 major shunts, including the ductus venosus, the foramen ovale, and the ductus arteriosus. So we have the placenta, the lungs are non-functioning for gas exchange, and we have high pulmonary vascular resistance with minimal pulmonary blood flow, and we have a low systemic vascular resistance due to the placental circulation. And we do have 3 major shunts: the ductus venosus, which bypasses the liver and connects the umbilical vein to the IVC; the foramen ovale, which shunts the oxygenated blood from the right atrium to the left atrium, and this blood is coming from the ductus venosus and directed to the foramen ovale by the Eustachian valve. And the ductus arteriosus is in the fetal life is called ductus arteriosus, and if it remains patent after birth, it is called patent ductus arteriosus. And this ductus arteriosus shunts the RV cardiac output from the pulmonary artery to the descending aorta. So the right ventricle cardiac output, only 10% of it will go to the lung, and the rest of the right ventricular cardiac output will cross the ductus arteriosus to the descending aorta. So this is the fetal circulation. We have the placenta, and we have 3 shunts: ductus venosus, ductus arteriosus, and foramen ovale. After birth, so just the right atrial flow, most of the blood crosses the foramen ovale to the left atrium, left ventricle, ascending aorta, and this is the highest oxygenated blood, which will supply the brain and the heart, and the remaining blood go to the right ventricle, and from there it will go to the pulmonary arteries, ductus arteriosus, and to the descending aorta. The oxygenated blood returns via the umbilical artery to the placenta, and the ductus arteriosus is very important as it carries almost 50% of the of the cardiac output. After birth, there is loss of placental circulation, so that the systemic vascular resistance will increase because of the clamping of the loss of the placenta and clamping of the umbilical cords. And the lungs will expand, and this will lead to dramatic reduction in the pulmonary vascular resistance. This will lead to increased to oxygen and increase in VO2. The foramen ovale also will close due to increase in the venous return to the left atrium, which will push the flap of the foramen ovale against the septum. And the ductus arteriosus also will constrict due to increase in the VO2 and decrease in the placenta and the prostaglandins secreted from the placenta. After the first breath, the pulmonary vascular resistance will drop within minutes, and the foramen ovale will close functionally within hours, but it might take months or years to close anatomically. The ductus arteriosus will constrict within 12 to 24 hours, but full closure will occur within 2 to 3 weeks. So if you have a baby with patent ductus arteriosus after 1 month, for me, this is our observation, if there is a patent ductus arteriosus in the first days of life, this will close, for sure it will close. But if this ductus arteriosus will remain patent after the first month of life, this patient will have a persistence of the ductus arteriosus. So he will have PDE, which might require intervention. Failure of transitions of this fetal circulation might lead to persistent pulmonary hypertension because of the failure of the pulmonary vascular resistance to drop, or the ductus arteriosus might remain patent, especially in prematures and in patients with hypoxia. What is the mechanism of prostaglandins? Prostaglandins mimics the other prostaglandins, which will lead to increase in the cyclic AMP and reduce cytosolic calcium. This will lead to vasodilatation, and this might lead to maintaining the patency of the ductus arteriosus. Factors affecting PDA patency: there are factors which might promote PDA opening or factors which might promote PDA closure. Factors which will promote PDA opening include low oxygen tension, acidosis, prostaglandins, and prematurity. Factors which will promote PDA closure include high oxygen, normal pH, non-steroidal anti-inflammatory drugs, and term gestation. In non-steroidal anti-inflammatory drugs, this is very important, especially during pregnancy. If the mother is using aspirin or other non-steroidal anti-inflammatory medications, this might lead to ductal constriction, which might lead to RV failure, and the baby might die. Presence of the ductus arteriosus in utero is very important. If the ductus arteriosus constricts, it will lead to ductus stenosis or constriction, which might lead to RV failure and hydrocephalus, and we might lead to fetal demise. When to suspect ductal-dependent congenital heart diseases? Actually, all ductal-dependent congenital heart diseases might look okay until the ductus closes. So we observe a lot of patients are discharged after delivery, 12 hours, 24 hours after delivery, with almost normal oxygen saturation, and to appear in the ER in cardiogenic shock. So if you have a suspicion of a congenital heart disease in the neonate, don't discharge the neonate and ask for echocardiography. They present immediately after birth or at 5 to 10 days of life. Which one will present immediately after birth? Those with significant cyanosis. But if there is no significant cyanosis, the baby might be missed and you will be discharged to present in cardiogenic shock. Like patients with, we saw patients with hypoplastic lethal syndrome presenting to the ER in shock. We saw a lot of patients with coarctation of the aorta presented to the ER in cardiogenic shock. But patients with TGE, they will present immediately after birth with cyanosis. Patients with pulmonary also will present also with cyanosis. The patient might present with cyanosis, which could be differential cyanosis, like patients in coarctation of the aorta will have a lower limb saturation will be lower than the upper limb saturation, or the preductal will be higher than the postductal saturation. Or they might present in shock with poor perfusion in patients with ductal dependent systemic blood flow. Ductal dependent systemic blood flow. There might be also severe metabolic acidosis, and you might have a murmur with absent femoral pulses. Sometimes there is no murmur. So absence of murmur will not exclude congenital heart diseases. واضح يا دكتور أسامة؟
واضح واضح يا دكتور علي.
ممتاز. So ductal dependent congenital heart diseases might manifest with non-specific symptoms. Non-specific, like patients with heart failure symptoms. And the heart failure symptoms also in infants and neonates are non-specific also. Like tachypnea, poor feeding, pallor, decreased wakefulness, or the baby may appear as he is not looking well. The mother says that I think that my baby is not looking well. So you have to take this note. Mother comments are very granted, and you have to take it and exclude any abnormality in this unit. The findings that suggest congenital heart disease include abnormal cardiac impulses on palpation or on observation. I mean, as I mentioned before, if you have an active precordium in the unit, this is abnormal. Abnormal is not until birth, but it's for sure it is abnormal. For sure it is abnormal. If you have pathologic murmur, if you have discrepancy between the preductal and postductal saturations, pulses, or blood pressure. But the most important thing, you might have no discrepancy in the blood pressure. You might have no discrepancy in the pulses, especially if you have a large ductus. But you might have discrepancy in the saturations, either differential cyanosis or reverse differential cyanosis. I found this very important, or very important knowledge about the ductus size. The ductus size, very interesting actually. In patients with like patients with aortic atresia, for example, aortic atresia, patients with systemic outflow tract obstruction, hyplastic left heart syndrome. In utero, all the cardiac output should go to the right side. And from the right side, it should go to the lungs. But the lungs are deflated and filled with water, and the pulmonary vascular resistance is high. So where that blood should go, that blood should go through the ductus arteriosus. That's why in systemic outflow tract obstructions, you found that the ductus is large, huge ductus, as this ductus, and the second in B. But in patients with pulmonary dependent, PDA dependent pulmonary circulation, like patients with critical pulmonary stenosis, not critical pulmonary stenosis, I will see pulmonary. So the blood will cross to the left side, to the foramen ovale. Most of the blood will cross to the foramen ovale, to the left ventricle, and from the left ventricle, it will distribute through the ascending aorta, transverse aortic arch to the descending aorta. That's why we have in patients with conotruncal anomalies, the aortic root is dilated, the isthmus is large, and the ductus is tortuous and small. This is I found this very interesting knowledge. So in left-sided obstructions, a larger proportion of the cardiac output has to cross the ductus to maintain a normal cardiac output, resulting in a wider ductus. In right-sided obstruction, the volume of blood crossing the ductus is lower than normal, resulting in a narrower ductus, and its connection with the aorta has an acute inferior angle. We have some examples of systemic prostaglandin dependent systemic systemic outflow tract obstructions, which are prostaglandin dependent, like patients with critical left-sided obstructive lesions, including hypoplastic left heart syndrome, and this includes the hypoplasia of the LV, mitral, small mitral valve, mitral atresia, small aortic valve, aortic atresia, small ascending aorta, plus minus coarctation of the aorta. So the blood, the systemic circulation should be supported by the BDE. And we have critical aortic stenosis. And in critical aortic stenosis, something important is to have a good interarterial communication so that the blood will not stagnate in the left side and will cause pulmonary venous congestion, pulmonary venous hypertension. A neonatal coarctation of the aorta and interrupted aortic arch. So we have patients with hypoplastic left heart syndrome, and we have patients with coarctation of the aorta. In coarctation of the aorta, actually, to sometimes if you have a large ductus, you might not have a significant gradient across the coarctation, but there are some two-dimensional echocardiographic predictors for the presence of coarctation. So if you have doubt, is it coarctation, not coarctation, and the patient is having a large ductus, you shouldn't discharge the baby until you are sure 1000%, not 100%, 1000% that the patient is not having coarctation of the aorta. How to identify that there is or there is no coarctation of the aorta? In the absence of significant gradient across the aortic isthmus. Actually, I published a paper about this point, named two-dimensional echocardiographic predictors of coarctation of the aorta, including abnormal mitral valve, abnormal aortic valve, and abnormal aortic arch subclavian index, aortic arch subclavian index. You will find that there is a significant displacement of the left common carotid artery with a long distance between the left, significant displacement of the left subclavian artery with a significant long distance between the left common carotid artery and left subclavian artery. So the distance between this artery and this artery would be long. And you will find that the aortic arch is a little bit hypoplastic. This arch is hypoplastic. And if you compare this distance between the aortic arch branches and the aortic arch, the transverse arch, you will find that the distance is larger than the transverse arch, or the distance will be either equal or more than the ascending order. So in these cases, there is coarctation until proved otherwise. So better not to discharge the baby. You might challenge the baby, don't start prostaglandin until you are sure that there is no coarctation of the aorta. And interrupted aortic arch with all of its types. That's why when we assess for differential cyanosis, we have to mention preductal as the right hand and postductal as any one of the lower limbs. Preductal and postductal. Preductal is the right hand and postductal any of the lower limbs. And we have that is the left-sided obstructive lesion, and this is the right-sided obstructive lesion, or critical right-sided obstructive lesion, or prostaglandin-dependent pulmonary circulation. We have the patients with critical pulmonary stenosis. We have patients with pulmonary atresia, and patient pulmonary atresia, we have two types: pulmonary atresia with intact septum or pulmonary atresia with VSD. And pulmonary atresia with VSD is very important also to recognize that the patient is having either MAPCAS or BDE. And you have to make sure that the pulmonary arteries, is there any pulmonary artery which is prostaglandin dependent? Native pulmonary artery which might be prostaglandin supported or supplied by the BDE. How to confirm that? You have either to do cardiac CT or cardiac cath. So better to do a cardiac CT. If there is no ductus arteriosus supplying native pulmonary artery, you didn't need to give prostaglandin and you can discharge the baby. But If you have native pulmonary arteries which are supported by the ductus arteriosus, you have to secure those native pulmonary arteries by starting prostaglandin infusion, and you have to plan for intervention, either PG stent or PT shunt, to maintain the patency of these native pulmonary arteries. And we have complex congenital heart diseases with critical pulmonary stenosis, subpulmonary stenosis, or pulmonary atresia, or we have patients with functional pulmonary atresia. So we have pulmonary atresia with intact septum. There are varieties of, wide spectrum of these lesions, depending upon the size of the tricuspid valve and the RV, or tricuspid atresia. And in patients with tricuspid atresia also, you have to make sure that the interatrial communication is sufficient to maintain the crossing of the blood from the right atrium to the left atrium. Sometimes the VSD is restrictive, but there is no PS. In patients with tricuspid atresia with normally related Greek arteries. You have to make sure that the restriction is sufficient so that you have to protect the pulmonary vascular bed for future interventions. Sometimes it's difficult to tell because there is no BS, but the restriction is at the VSD level. You might need to go for augmentation or no augmentation. This is a tricky point also in these patients. And we have patients with critical or pulmonary stenosis, either sub-PS, PS, or supra-PS. How to evaluate neonates with ductal dependent pulmonary circulation? As we mentioned, that we have to check the pulses in both the upper and lower extremities, and we have to check the saturation in both arms and any of the lower limb. So if you have a patient with interrupted aortic arch, you might have a high blood pressure in the upper limb with a lower or equal blood pressure in the lower limb, but the saturation will be different, and this is called differential cyanosis. But if you have a patient with TGE, you will have the blood pressure might be equal in both upper limb and lower limb, but the saturation will be higher in the lower limb because of the oxygenated blood coming from the LV crossing the ductus arteriosus and going to the lower limb, and this is called reverse differential cyanosis. And we have this anomaly also. It's very rare. I saw only one case, which is called ventricular inversion, and the patient will present also with pathophysiology of TBE. Other important lesions to evaluate and to decide early in the neonatal period is neonates with single ventricle pathologies. What is the meaning of single ventricle pathologies? Include one functional ventricle, either the LV or RV, which support both the systemic and the pulmonary circulation. Examples of such lesions include hypoplastic left heart syndrome, tricuspid atresia, double inlet left ventricle, double outlet right ventricle with remote VST and or straddling AV valves, and pulmonary atresia with intact septum if the RV is significantly hypoplastic. So we can take the decision will be easy in patients with hypoplastic left heart syndrome, tricuspid atresia, and pulmonary atresia. Pulmonary atresia is a little bit tricky also, especially if the RV is borderline. But if you have a patient with double inlet left ventricle or single ventricle indeterminate ventricle, you have to take a decision what to do immediately after diagnosis in the neonatal period. Otherwise, you might miss the patient. The patient will be mismanaged if not properly planned in the first diagnosis. So we have patients, a lot of examples of single ventricle pathologies, including double inlet left ventricle, single inlet left ventricle, common inlet left ventricle, or the patients with double outlet right ventricle with remote VECDs or significant straddling overriding of the AV valve. So as I mentioned, you have to plan the management of such patients once you diagnose them. Once you diagnose, you have to plan them and you have to track them with proper management. So you have to balance between the pulmonary and systemic blood flow. If there is excessive blood flow, pulmonary blood flow, the patient will have heart failure and the TBTS might be more than 2 to 1. Or the patient might have inadequate pulmonary blood flow and the QPQS will be less than 1 to 1. The systemic outflow tract also, you have to assess the systemic outflow tract patient. The patient might not have systemic outflow tract obstruction, or he might have coarctation of the aorta, interrupted aortic arch, or significant LVOT obstruction due to deviation of the outlet septum posteriorly or small bulboventricular column. The patient also might have inadequate mixing with restrictive ESD or VCD. You have to decide that the patient is amenable for single or biventricular future repair. This is very important. You have to decide it immediately after diagnosis. And do we need to give prostaglandin infusion or no? And do we need to do balloon atrial septicectomy? Do we have any questions till now? Is it clear, Dr. Osama?
Yes, yes. We'll leave the question until the end.
Okay. So if you have a patient with single ventricle pathology, ask yourself, could it possible to be repaired as biventricle? Do we need to give prostaglandin infusion? Do we need to do balloon atrial septicectomy? Do we need to do urgent cardiac surgery or cardiac intervention? So these are very important, and you have either the patient is having single ventricle pathology or neonate with congenital heart disease. So you have to ask yourself, is it possible to this pathology will be a biventricle or single ventricle? Do I need to give prostaglandin infusion or no? Do I need to do balloon atrial septicectomy or no? Do we need to do urgent intervention or no? Either cardiac surgery or cardiac care. So you have to assess the upper limb, lower limb circulation. You have to assess the status of the pulmonary blood flow, and you have to assess the status of the systemic blood flow. How to assess the status of the pulmonary blood flow? The pulmonary blood flow might be normal, no restriction, or there is restriction. So there is, if it is just a pathology, congenital heart disease, fine. But if you have a patient with single ventricle, neonate with single ventricle pathology, you have to assess the pulmonary blood flow. And this pulmonary blood flow might be restricted in the form of PS or sub-PS, and his saturation is around 70 to 85. In this condition, we'll accept this. Will accept this, and the patient might not require prostaglandin infusion, and he might not require any intervention at this point. Or the saturation will be less than 70 plus minus metabolic acidosis. In these cases, there might be significant restriction in the pulmonary blood flow, and the patient might need to have augmentation of the pulmonary blood flow. How to augment this pulmonary blood flow? By either doing balloon pulmonary valvuloplasty if it is doable, or to stent the ductus arteriosus, or to put a petition. So this also, either the patient might have borderline saturation, or he will have severe restriction with a low saturation plus minus metabolic acidosis, or he had pulmonatresia. This is pulmonatresia is very clear. But if you have borderline saturation or restriction, you have to decide or observe the baby, and you might need to give prostaglandin infusion and to do intervention after diagnosis. So if there is severe restriction or pulmonatresia, the patient will require augmentation of the pulmonary blood flow by either BD stent or petition. So we assess the pulmonary blood flow. Now you have to assess the systemic blood flow. You might have patients with adequate cardiac output, so there is no problem now. or you might have restriction in the systemic outflow tract with AS or sub-AS, and the patient might present with shock and metabolic acidosis, or very clear issues in which there is clear severe aortic stenosis, critical aortic stenosis, coarctation of the aorta, aortic atresia, LV hyperplasia, or interrupted aortic arch. And in these cases, you have to start prostaglandin, and these patients you will not be able to discharge them from the hospital until you do intervention for them. The cyanosis could be related to the heart or to the lung. How to differentiate between these two conditions? Cyanosis related to the heart, the patient will be convertible at rest. The cyanosis will worsen with crying. You might auscultate and there is a murmur. You might have abnormal cardiac slowing in the chest X-ray with normal lung fields. The ECG might be abnormal. PCO2 will be normal, and hyperoxia test. Nowadays we are not doing hyperoxia test. Once you have a baby with abnormal saturation, start prostaglandin and do echocardiography. Don't waste your time. If the cyanosis is related to the lung, the baby will be tachypneic, distressed with subcostal recession. If the baby cries, the cyanosis might improve. There are rails and crackles with wheezes in auscultation, and the chest X-ray you will have abnormal lung fields. Normal ECG, the CO2 might be high, and the baby will respond promptly to oxygen. How to give prostaglandin and what are the side effects? The initial dose of prostaglandin, you might start with between 0.01 to 0.05. Sometimes you might need to increase the dose to 0.1 microgram per kg per minute. But high doses, you might have the baby will develop hypotension or apnea, and you have to be ready for intubation. The maintenance dose usually will give 0.03 mics per kg per minute. And you have to taper the dose if stable, and you have to repeat the echo to make sure that the ductus is of good size. If it is a huge ductus, you have to reduce the dose to the minimum. Usually we are maintaining the dose of prostaglandin between 0.0 to 0.03. You have to be alert to the side effects of prostaglandin, including apnea, which might occur in 20 to 30% of neonates, and you have to be ready for intubation. Patients might develop also hypotension, fever, or seizure, which are rare. You have to monitor the pre and postductal saturations, and to do blood gases and to assess the lactate level. Also, you have to depend. Also, we are depending on the echo for titration of the dose of prostaglandin. There is no absolute contraindication to prostaglandin. Actually, prostaglandin is like magic medicine. اللي يؤمنون بالغيب الذين يؤمنون بالغيب يشوف البروستاجلاندين صراحة. يعني this is one of the tricks يعني in medicine. سبحان الله. If you will see the baby in the ER, you will do echo. The ductus is very small, restricted, and the baby is in shock. Start prostaglandin. Within 30 minutes, you will see the effect, real effect in front of your eyes. Just magic medication. Magic medication. You will see the effect of prostaglandin opening the ductus upstairs, and the baby will start relaxing, and the acidosis will improve. These are some just examples of prostaglandin dependent agents, pulmonary fluid dependent, systemic fluid dependent, or mixing dependent, like patients with TB restricted ESD and TB isolated mitochondria. If there is no good mixing at the atrial or molecular level. The pulse oximetry. Actually, nowadays there are guidelines from the American Academy of Pediatrics. It is mandatory to do pulse oximetry screening test for critical congenital heart disease. It will not exclude all congenital heart disease, and you might miss if you are not careful in doing pulse oximetry. You might miss some patients with coarctation of the aorta, or patients with single ventricle with high pulmonary fluid. So it will identify newborn with critical congenital heart disease before signs and symptoms develop and before discharge from the hospital. And pulse oximetry shouldn't replace complete history and physical examination. How to treat patients? As I mentioned, we have, once you have a baby with shock, you don't know what is going on with this baby, start prostaglandin immediately. If you have echo in your hand, do echo. If you don't have it, just start prostaglandin. And prostaglandin actually is a life-saving medication. We saw this on multiple of our patients. You will give oxygen, you will give fluid. Some patients might have total animal convergence defense, but even though if you are suspecting prostaglandin dependent lesion, PABD might be a related contraindication, but there is no absolute contraindication to prostaglandin. Just give prostaglandin, nothing will happen. Just be ready with the intuition or if the baby is intubated, that's it. You have to consider alternative diagnosis. Patients might have, if there is no congenital heart disease, the patient might have alternative diagnosis like dehydration, sepsis, intracranial hemorrhage, pneumonia, metabolic disorders, hyperglycemia. But if you see a 5 to 10 days old neonate in shock, besides usual medications, you will give usual medications, oxygen, fluids, antibiotics, start prostaglandin at once. It might be life-saving. That is prostaglandin dependent lesion. Now, just a brief account about neonatal cardiac arrhythmias, and we can classify neonatal cardiac arrhythmias into supraventricular tachycardia, and this comprises 90% of the neonatal cardiac arrhythmias. But if you can diagnose SVT easily, you can diagnose heart block easily, you can diagnose BVCs easily, but you might miss ectopic atrial tachycardia. This is very tricky actually. You will have a baby with a heart rate 120, 130, 140, but you might find some irregularities, and the P wave axis is abnormal. If you have a P wave axis, abnormal P wave axis, you have to be careful, and the baby might, with chronic, long-term effect of this arrhythmia, the baby will develop depressed cardiac function. We saw this also in multiple occasions. Complete heart block also associated with maternal anti-Rho antibodies, and ventricular tachycardia, which is rare also, and might be secondary to metabolic disorder or long QT syndromes. The ECG features of cardiac arrhythmias might have a heart rate above 220 beats per minute, narrow QR complexes, absent P waves. Absent P wave is very important. The ECG, you have to look at the P wave, or retrograde P wave, or abnormal P wave axis. How to manage? You will give, if the patient is stable, you might try vagal maneuver gently. Don't be so aggressive with vagal maneuver. If you have an IV line, you will give adenosine 0.1 milligram per kg rapid IV push. You can double the dose if needed. Unstable patient with hypotension, heart failure, you have to do synchronized cardioversion 0.5 to 1 joule per kg. You might need to give maintenance therapy like beta blockers, amiodarone, and prokinamide. Complete heart block causes include maternal lupus antibodies, or congenital structural heart diseases like L-transmission of great arteries. The management depends upon the presence or absence of congenital heart disease and the heartbeat. You might need to give isoproteinorone drip, or you might need to put a pacemaker. Neonatal myocardial dysfunction might be related to in utero processes or infections or metabolic disorder, or related to myocarditis. Or the patient might have arrhythmogenic cardiomyopathy, like patients with missed ectopic atrial tachycardia. We have one patient with congenital heart disease, and there was some abnormal rhythm, and we overlooked that abnormal rhythm. We concentrate on this in the congenital heart disease, and actually it was prostaglandin dependent lesion. So we gave prostin, and we missed or overlooked this abnormal arrhythmia. It was just just irregularity in the heart rate. With normal heart rate around 120, 130. So the patient was admitted, and within 2-3 days he was collapsed while in pristine. So we wonder. We repeated the echo, and the function was severely depressed, and that patient had ectopic atrial tachycardia. So you might have a patient with large heart, which is X-ray, tachypnea, hypotmegaly, and deterioration after fluid pulses. The types of cardiomyopathies include hypertrophic cardiomyopathy, dilated and restrictive. But we found that the patients with metabolic disorder will have hypertrophic cardiomyopathy. But some patients will have a normal echo in the first few months of life. I mean, after delivery, the echo might be normal after 1 month, 2 months, 3 months, and then he will start to have progressive hypertrophy of the left ventricle. And if you with time, you might identify patients with pathologic hypertrophic cardiomyopathy and just simple hypertrophy related to infant of diabetic mother, for example, which will be regressive. The regression, the hypertrophy or the thickness of the myocardium will regress with time. So my take-home messages is prostaglandin is a life-saving medication. Start prostaglandin empirically if you have suspicion of ductal-dependent lesion. The second key message is SVT is the most common arrhythmia, and adenosine is the first line of therapy. Cardiomyopathy requires tailored therapy, avoid influx in hypertrophic cardiomyopathy. And then early echo is critical in all neonates with cardiac emergencies. So if you have a baby in the ER presented with shock, do echo. I mean, if the ER physician consulted the pediatric cardiologist, no argument. You have to respond immediately and go to the ER and do the echo, to the ER, to the NICU, wherever. Neonates, don't play with neonates. Actually, I was in locum in Thai, and in the morning I was asking, do you have any patients with echo? They said, yes, we have one patient to go home for discharge. And then I start with that patient, just put the echo. I found that that patient is having total anomalous homogeneous return. You might have surprise things. I mean, that baby is ready to go home, and he's having a severe congenital heart, significant congenital heart. So if you have a neonate, if you are requested to assess a neonate, don't argue, just respond immediately. Thank you.
Thank you so much, Dr. Ali, for this comprehensive lecture. Many topics belong to this lecture. We can take 2-3 questions quickly before we end our activity today. You can write on the chat if you want. Just I will ask one question until somebody write. Dr. Ali, about the prostaglandin in total anomalous, especially if it is obstructive TABVD like infracardiac. Do you recommend to start prostaglandin as it has some pulmonary vasodilator effect?
This is what I mentioned. I mean, if you have an echo in your hand, I mean, it's easy access to pediatric cardiologist. Do echo. I mean, it's just put the probe. Usually, what we inform our resident, our fellows, when you go to the ER for a neonate, start do rapid check. Just make sure that you are not dealing with duct-dependent congenital heart disease. Once you have a baby with duct-dependent, don't continue doing echo. Ask for immediate prostaglandin infusion. I mean, don't waste time doing echo, perfect images. No. This patient is having pulmonary atresia. Ask for prostaglandin immediately. You have to raise the flag and announce, please, I need prostaglandin for this baby. This is one point. If you have a coarctation, same point. But if you don't have an access to early echo, you can start small dose. Don't start large doses. Don't start if you don't have access to echo. Don't start large doses. 0.05, 0.07, 0.1. No, start 0.02, 0.03. Nobody will tell you anything. Just 0.02, 0.03 will be sufficient just to maintain the baby until you have a correct diagnosis. So it's difficult actually to tell. But if you have an access to early consultation, early echo, this is the best.
Okay. Many questions about the record of the lecture. As I told you, they are working on all these things in the website. Inshallah, soon it will be available. Many questions about prostaglandin. I think Dr. Ali already answered. There is one question about oral prostaglandin, misoprostol. I don't know if Dr. Ali you want to comment on this.
I don't know about this.
We don't have experience with oral prostaglandin. We never use it. I don't know.
Difficult to dose actually.
One question about your case in Hail. Why echo requested and then you discover TABVD?
This is the baby was there is a murmur, no murmur like that. Yeah, this is just the neonates. Sometimes you like the mothers. Neonatologists are they are experts and they can pick patients who have some abnormality. So you have to believe on the neonatologist also.
The last question, is there any standard acceptable oxygen saturation in a patient with congenital heart disease?
It's not just a standard. You should have, if you have a baby, if you are dealing with a single ventricle, you shouldn't, a baby with the hypoplastic left heart syndrome, you shouldn't try to have a normal saturation. No, normal saturation is drastic. It's not good for the baby. You have to have a saturation between 70 85. This is the best for them. If a baby with prostaglandin dependent pulmonary circulation, for example, a baby with pulmonary, you have to accept any saturation. If you have a baby above 70 to 80, it's fine for them. But babies with single ventricle pathology, the best saturation is 70 to 85.
Okay, I will end with this question. Question about prostaglandin in infant in coarctation. I understand from the question that you want to ask until what age you can start prostaglandin if there is coarctation. Until what age in the neonate?
If it's a neonate, even less than 3 months, I will give actually. Especially if the baby presented. Yeah, if the baby presented with a shock, I might give prostaglandin because you have actually, even if the ductus is not present, if the ductus didn't open, actually there are ductal tissue in the coarctation segment. You have neonates, for example, you will give prostaglandin, the ductus didn't open. But if the ductus didn't open and the patient still having severe coarctation, the baby needs urgent surgery. But there are ductal tissue because one of the theories of the development of coarctation of the aorta is the presence of encircling ductal tissue in the aortic isthmus. So if you give prostaglandin, that ductal tissue in the isthmus, in the aortic, is not in the ductus arteries, in the isthmus, might respond to prostaglandin and it might
and see you inshallah in the next activity. Okay. Finished, Dr. Ali?
Yes, you get the point.
Yes.
Okay, thank you.
Okay, thank you, Dr. Ali, for your great lecture, and thanks for all the audience. See you, inshallah, in the next activity after 2 weeks. Assalamu alaikum wa rahmatullah.